Welcome everyone to this free webinar. I am M.helmy. I am lecturer and consultant of obstetrics and gynecology and mentor of Part 1 MRCOG and Med-Exam Expert. I'm happy to have you here in this free webinar in which we are going to talk about the main points regarding obstetric cholestasis. This topic is one of the applied topics related to pathology in Part 1 MRCOG exam, and of course it's an important guideline regarding Part 2 MRCOG exams also. So it's one of the important topics in which you can face one question in the exam or two questions talking about obstetric cholestasis, and of course it's very, very important for also those tackling Part 2 MRCOG. Also, by the end of this session, our course coordinator, Afia, she will talk to you about the Part 1 MRCOG course we are offering. And as I said in my post, that there will be a very good gift at the end of this session for those who attended this free webinar. So let's start talking about our topic today, obstetric cholestasis. And we are going to cover few important points, the diagnosis and monitoring of the condition. What are the risks associated with obstetric cholestasis? How to predict the fetal compromise? Is there a to predict the fetal compromise? Timing of delivery? How to treat the condition? How to follow up, and what is the prognosis of this condition? I will be grateful for all of you if you turn off your mics while I'm talking. How to predict the fetal. Okay, thank you. So, a quick introduction. In England, obstetric cholestasis, which is also known as the intrahepatic cholestasis of pregnancy, or it has the abbreviation of ICP, this condition affects 0.7% of pregnancies in multi-ethnic populations. And the most common affected populations are those of Indian, Asian, or Pakistani Asian origins, and also it affects some populations in the South American countries. The prevalence is also influenced by genetic and environmental factors and varies between the populations worldwide. So we can't say that there is a fixed incidence for this condition. It varies among the different populations. What are the risk factors of this condition? The exact etiology of the obstetric cholestasis is not well known or not well understood, but there are some risk factors, maybe some genetic factors, as it was found that there is some sort of positive family history in 35% of patients. So if a pregnant lady had a sister, for example, who experiences obstetric cholestasis, so she may be in a risk of also developing this condition. And some studies suggest that this condition may be inherited in an autosomal dominant pattern. So there may be positive family history, and the studies done on this condition have suggested that there is some sort of autosomal dominant inheritance. And some family studies also, from the risk factors affecting or which can lead to this condition is the estrogen hormone. Estrogen hormone, we know that estrogen increase in pregnancy, and the elevated estrogen levels can cause a significant impairment in the sulfation capacity of the bile acids. What's meant by sulfation capacity? Sulfation is a process by which the bile acids are conjugated to sulfate to be more water soluble to help its excretion. The high level of estrogen cause some sort of impairment of the enzyme responsible for this process. This leads to failure of excretion and getting rid of these bile acids. So the bile acid build up in the body, causing the pathogenesis of this condition. A proof of that is that in some studies they found that similar condition happened in some females receiving combined oral contraceptive pills, as it precipitated a similar syndrome. And of course, we are going to talk about the clinical manifestations of this syndrome in a while. Also, the reproductive hormones, the estrogen and progesterone, affect the function of bile acid transport within the hepatocytes. So, the hormones of pregnancy will lead to some sort of failure of transport and excretion of the bile. And as this is the liver and the hepatobiliary system, the failure of excretion of the biles to be secreted in the stool and secreted in the GIT will lead to accumulation of the bile. It will increase in the circulation. The absence of secretion of the bile in the GIT will lead to malabsorption of food, especially fat, and the increase of the bile acid in the circulation will lead to the different symptoms of the obstetric cholestasis. Other risk factors include multiple pregnancy, those patients with hepatitis C virus, and also the presence of gallstones. All these risk factors can precipitate the condition of obstetric cholestasis. Am I clear so far?
Yes, sir.
Okay. So, how to diagnose and monitor obstetric cholestasis? First, let's start by the diagnosis. How is obstetric cholestasis diagnosed? We have two main points or two main manifestations or signs. If they are present, the condition is most probably is obstetric cholestasis, but in one condition, after we exclude other organic causes. So obstetric cholestasis is diagnosed when there is unexplained pruritus and abnormal liver function tests or raised bile acids. So we have a clinical manifestation or a sign, which is the pruritus, and we have laboratory one, which is abnormal liver function tests or raised bile acids. Both occur in pregnant women and resolve after delivery. Usually this condition develops in the second half of pregnancy, during the third trimester, and 80% of the cases present after 30 weeks. So we have pruritus and we have abnormal liver function test or raised bile acid. Both resolve after delivery, and most commonly this condition will present after 30 weeks gestation. What are the characters of the pruritus of obstetric cholestasis? Of course, it's pruritus without rash. It's typically worse at night. It's widespread and involve the palms of the hands and or the soles of the feet. And this is a very important point. And usually when you see the questions of part 1 MRCOG, and if you have a clinical scenario talking about obstetric cholestasis, usually the examiner put this keywords that the pruritus involving the palms of the hands and all the soles of the feet. But you have to exclude other causes of pruritus. So we can say that obstetric cholestasis is a diagnosis by exclusion. So first, you have to be sure that there are no other organic causes of pruritus before giving a confirmation that this is obstetric cholestasis. Also, when we deal with the pruritus of obstetric cholestasis, you should inspect the skin very well to exclude any rash and also to differentiate between the skin trauma from the intense scratching from other common skin conditions such as eczema or atopic eruption of pregnancy. But if you find a rash, so you should consider other skin disorders like the polymorphic eruption of pregnancy or the pemphigoid gestationis or the blisters. So if you find a rash with the pruritus, here you have to think about skin or dermatological conditions, not obstetric cholestasis, as the pruritus of obstetric cholestasis is not associated with rash. But you may find some skin trauma from the intense scratching. It's called dermatographia artifacta. This is a skin trauma from the intense scratching, and you have to be very careful when inspecting the skin of the patient to differentiate between the trauma and the rash. I have a question in the chat. Why pruritus over palms and soles? It's distributed all over the body, but it's also found in the palms and the soles, and this is very characteristic of the obstetric cholestasis, as the bile acids accumulate and in the skin and the dermis and causes this pruritus. Usually other skin conditions doesn't involve the palms and the soles, but due to the wide distribution of the bile in the circulation, it affects also the peripheries, and that's why it's a character of the obstetric cholestasis. The other arm of diagnosis is the abnormal liver function tests, or the laboratory part. In clinical practice, if we have unexplained abnormalities in the liver enzymes, the transaminases, the gamma-glutamyl transferase, and or bile salts, these are considered sufficient to support the diagnosis of obstetric cholestasis. So when we have unexplained elevation of liver function test, and we are sure that there are no other organic causes, the patient has no hepatitis, for example, no drugs, she's not taking any drugs which may affect the liver functions or so. So this may support the diagnosis of obstetric cholestasis. And we should put in our mind to use the pregnancy-specific reference ranges for the liver function test. We should note that the upper limit of liver enzymes and bilirubin, that they are 20% lower in pregnancy than the non-pregnant range. So we have to use the pregnancy-specific reference ranges. This is, of course, in our clinical practice. In some cases, women may present with only pruritus and with normal liver function tests. And in these cases, we have to repeat the liver function test every 1 to 2 weeks until we confirm the diagnosis of obstetric cholestasis. And also, very rare cases, there are isolated elevation of bile salts, but this is not common. And also, normal levels of bile salts do not exclude the diagnosis. So we may find in some cases isolated elevation of bile salts, but this is uncommon. And also in some cases of obstetric cholestasis, we find normal levels of bile salts. So normal levels of bile salts do not exclude the diagnosis. Clear? Okay. What are the other evidence of cholestasis or other clinical manifestations? Of course, pale stool due to absence of the bile in the stool, dark urine because of the accumulation of the bile pigments in the circulation, and it will be excreted in the urine. Jaundice, but this is not common manifestation in obstetric cholestasis. Sometimes the bilirubin levels are elevated, but this is a mild to moderate elevation. So jaundice is not a common manifestation of obstetric cholestasis. Of course, anorexia and malabsorption of fat with steatorrhea, and of course, to find the risk factors in the patient you are dealing with. So these are the evidence or other clinical manifestations of obstetric cholestasis. If liver function tests are normal, we repeat every 1 to 2 weeks, yes. And if they are abnormal and symptoms also present, how frequently will we repeat the liver function test? And I'm going to say that in the monitoring part now, okay? First, before confirming the diagnosis, we have to exclude other causes of pruritus and abnormal liver function tests. That's a very important point, as I said in a while before, that the diagnosis of obstetric cholestasis is a matter of exclusion. You have to exclude first any other organic causes of pruritus and abnormal liver function tests. So these causes are the gallstones, and of course we can diagnose the gallstones by the imaging techniques. Hepatitis virus, infection to the liver, Epstein-Barr virus, and cytomegalovirus. All these can lead to some sort of abnormal liver function test, and also any affection to the liver or the hepatobiliary system can lead to upregulation of or up rising of the bile acids and bilirubin and so on. So we have to exclude any infection in the liver, hepatitis, Epstein-Barr, cytomegalovirus, and this is of course done by viral serology. Also, you have to exclude some autoimmune conditions like the chronic active hepatitis and primary biliary cirrhosis. These are autoimmune conditions which lead to destruction of the hepatobiliary cells or hepatobiliary system, and these are diagnosed by finding some antibodies in the blood like the anti-smooth muscle antibodies and the anti-mitochondrial antibodies. Also, you have to exclude preeclampsia and acute fatty liver of pregnancy. These are pregnancy-specific causes of abnormal liver function test that might form a part of differential diagnosis in atypical or early cases. Some atypical or early cases of obstetric cholestasis can lead to abnormalities in the liver function test before pruritus appear. So also you have to exclude preeclampsia and acute fatty liver. How should we monitor obstetric cholestasis? Once we diagnose, we have to measure the liver function tests weekly until delivery. And this is the answer of the question I had in the chat now from Dr. Rabika, that we have to monitor the liver function test weekly until delivery. And also we should do a coagulation screen or the coagulation profile. Why we should do a coagulation profile? What do you think? Can anyone answer?
Vitamin K is not absorbed.
Exactly. There is a malabsorption of fat, including fat-soluble vitamins, and this, of course, include vitamin K. So there may be some sort of vitamin K deficiency in cases with obstetric cholestasis, and this may affect the coagulation profile. So we should also do a coagulation screen. Postnatally, after delivery, liver function test should be deferred for at least 10 days because in normal pregnancy, liver function test may increase in the first 10 days of the puerperium. So the results of the liver function test in the first 10 days after delivery will be inaccurate. So you have to defer the liver function test screening after 10 days of delivery. Now, moving to another point, which is the risks associated with obstetric cholestasis. And we can simply divide them into the maternal risks and the fetal risks. For the mother, the first risk will be vitamin K deficiency due to the malabsorption of fat-soluble vitamins. And of course, this can impair the coagulation profile and the homeostasis or the hemostasis in her blood and increase the risk of postpartum hemorrhage. The second one is increase the rate of cesarean section from 10% to 36%. However, we cannot establish why cesarean section rates are high in obstetric cholestasis. Maybe due to the pathology itself, which can lead to some sort of fetal distress and early delivery, as we are going to see in the fetal risks, or maybe due to the increased rate of induction of labor. And we are going to explain that in the timing of delivery, why we have to induce labor at a certain gestational age, or maybe due to obstetrician or patient anxiety. As once we diagnose obstetric cholestasis, there is a lot of fears regarding the fetal risks and the incidence of the stillbirth and perinatal mortality. So obstetricians may have some worries of allowing normal vaginal delivery. So they may offer the lady cesarean section, and also the patient anxiety will force her to accept that decision. The vitamin K deficiency, which is one of the pathophysiological events happening on obstetric cholestasis, plus the cesarean section rate may cause a possible increase in the risk of postpartum hemorrhage. However, in the clinical practice or the evidence from the current clinical practice does not show that significant increase in the risk of postpartum hemorrhage in cases with obstetric cholestasis. So, vitamin K deficiency, cesarean section rates, a possible increase in the risk of postpartum hemorrhage are considered the maternal risks associated with obstetric cholestasis. Moving to the fetus, we have many risks which can occur to the fetus, but you have to put in your mind that up till now, the mechanisms whereby the obstetric cholestasis may adversely affect the fetus are not known. And that's the challenging point. We don't know the mechanism by which the fetus is affected in cases of obstetric cholestasis. And that's why, as we are going to say in a while, that this put a difficulty for the obstetrician to predict the fetal compromise. Because we don't know the pathogenesis or the pathophysiology, so biologic, we cannot predict when and how the fetal compromise occur. But the obstetric cholestasis is linked to many fetal risks like stillbirth. Stillbirth in obstetric cholestasis can occur at any gestational age, but it increases towards term. And the challenging point here that it does not correlate with maternal symptoms or transaminase levels. So it's a sudden condition. The current additional risk of stillbirth in obstetric cholestasis above that of the general population has not been determined, but it is likely to be small, not that huge risk, slight increase in the rate of stillbirth. And the perinatal mortality rate in obstetric cholestasis, and this is a very important exam question, but for part 2 MRCOG, it's 5.7 per 1,000, 5.7 per 1,000. Also from the fetal risks occurring with obstetric cholestasis, the intrapartum fetal distress, we can find abnormal fetal heart pattern, fetal bradycardia or tachycardia or decelerations. Another risk is passage of meconium in the amniotic fluid, and this is more common in preterm stasis. May I ask you to please close or turn off your mics? Thank you. So another risk is the passage of meconium in the amniotic fluid, but this is seen more in those preterm pregnancies than in term obstetric cholestasis pregnancies. And the meconium passage may be more common in those with severe cholestasis, which is defined as bile acids over 40 micromoles per liter, compared with mild cholestasis when the bile acids are under 20 micromoles per liter. So here, the passage of meconium is somehow related to the level of bile acids. But as I said, we don't know exactly how the obstetric cholestasis cause these fetal risks. Also, preterm delivery, and much of the prematurity here is iatrogenic. Like I said, the anxiety of the obstetrician and the patient may force them to take a decision of early delivery, especially if they notice some sort of fetal compromise, intrauterine fetal death, sudden intrauterine fetal death, and fetal intracranial hemorrhage due to vitamin K deficiency. So these are all the fetal risks which may be associated with obstetric cholestasis. Am I clear so far?
Yes, sir.
Okay, good. So the exact magnitude of these risks is difficult to determine, especially as management protocols have included early delivery before the perceived maximum time of risk for the fetus. As we are going to say in the timing of delivery that now the protocol is to deliver the baby earlier at 37 weeks, and usually the maximum time of risk to the fetus is after 37 or 38 weeks gestation. So the perinatal mortality rates have fallen from 11% in earlier studies to 0 to 2% in more recent series in which women were delivered before 38 weeks gestation. How to predict the fetal compromise? And as I said, we don't know the pathogenesis or the pathophysiology. So of course, to predict the fetal compromise will remain the most difficult aspect in the management of intrahepatic cholestasis of pregnancy. As the fetal death is usually sudden, we don't have any detrimental effect of the condition on the Doppler flow studies. The uterine, the umbilical, the fetal cerebral arteries are normal, even in severe cases of intrahepatic cholestasis of pregnancy. There is no evidence of placental insufficiency. Fetal growth restriction and oligohydramnios also are not features of the disease. So we don't have obvious signs to be able to predict the fetal compromise. Sudden death of the fetus, no compromise to the Doppler studies, no compromise to the placental flow, no fetal growth restriction, no oligohydramnios. So how come we predict the condition? So it's so difficult. Usually, the risk of a given complication of intrahepatic cholestasis of pregnancy is higher if a woman has suffered that complication in a previous pregnancy. That's a way to predict some sort of the fetal complications, that if this mother had a previous pregnancy with obstetric cholestasis, she might suffer the same complications again in this pregnancy if she developed also obstetric cholestasis. No specific method of antenatal fetal monitoring for the prediction of fetal death can be recommended. And that's one of the Green Top guideline recommendations or highlights that no specific method of antenatal fetal monitoring for the prediction of fetal death can be recommended. Ultrasound and CTG are not reliable methods for preventing fetal death in obstetric cholestasis. However, you should offer a continuous fetal monitoring during labor. Once the lady is in established labor, you have to offer continuous fetal monitoring because sometimes you may discover some intrapartum changes in the fetal heart rates, which may indicate to make a cesarean section or make category 1 or category 2 cesarean section. One of the best predictors of fetal compromise is the passage of meconium. Passage of meconium in the amniotic fluid may offer the best predictor of fetal compromise. But it's very difficult to diagnose that because if we need to diagnose passage of meconium, we need some invasive processes like amniocentesis, transcervical amnioscopy after 36 weeks of gestation. These are too invasive, and up till now, there is absence of strong evidence that the results obtained are useful or can change the prognosis of the condition. So it's not an acceptable way to predict the fetal compromise. So if we want to summarize that part, there is no way to predict the fetal compromise, or no recommended methods, whether ultrasound, CTG, and so on. These are not recommended or cannot predict the fetal compromise. Usually the risk, if happened in a previous pregnancy, may be repeated in the current pregnancy. That's a way to predict the complication. Another way is to detect meconium in the amniotic fluid, but as I said, it's too invasive and not acceptable to be done routinely. And the thing you have to do is to decide early delivery plus offering intrapartum fetal monitoring. High bile acid levels have been linked with fetal death, passage of meconium, abnormal CTG, prematurity, and non-fatal asphyxial events. However, poor outcome cannot also currently be predicted by biochemical results, and also delivery decisions should not be based on results alone. So when we manage a case of obstetric cholestasis, we cannot depend on the biochemical results alone to decide delivery. Yes, the bile acid levels, when they are high, it has been linked to the fetal compromise, but up till now, we don't have a confirmation, we don't have a strong evidence that the high bile acid is the major cause or the real cause of the fetal compromise. Am I clear? Okay. So, until the pathophysiology of obstetric cholestasis and fetal death is more clearly defined and the level of risk is clarified, prediction and prevention of fetal death will remain challenging. There are currently insufficient data available to inform decisions about the best intervention to prevent fetal death, but a relationship with bile acid levels is suspected and remains the focus of much research. And that's considered the summary of that part of the prediction of the fetal compromise. When to offer delivery to a patient having obstetric cholestasis. According to the Green Club guidelines, a discussion should take place with women regarding induction of labor after 37 weeks of gestation. Stillbirth, as I said before, in obstetric cholestasis have been reported across all gestations, but the risk is more towards term, especially after 37 weeks. And as gestation advances, the risk of delivery, prematurity, respiratory distress syndrome, failed induction, versus the uncertain fetal risk of continuing the pregnancy, which is the stillbirth, the major fetal risk, may justify offering women induction of labor after 37 weeks of pregnancy. So, to make a balance between the risk of prematurity and the risk of continuing pregnancy, most of the research and studies have agreed that the best time to offer delivery is after completing 37 weeks of pregnancy, especially if the ladies suffering the condition have more severe biochemical abnormality. This will justify the decision, or the case for intervention at this gestation may be stronger in those with more severe biochemical abnormality. So we can say, when you find a case of obstetric cholestasis, it's better to deliver after 37 weeks of gestation, especially if the patient had more severe biochemical abnormality. The widely adopted practice of offering delivery at 37 weeks of gestation or at diagnosis, if this is after 37 weeks, is not evidence-based up till now. Therefore, the iatrogenic consequences of elective delivery must be considered. And that's why this decision must be done after a very thorough and careful counseling with the patient. You have to tell her that we are offering induction of labor at 37 weeks because we want to make a balance between the risk of prematurity or the risk of continuing pregnancy and the stillbirth. And she must share in the decision, as this is up till now is not an evidence-based. Maybe she needs, or maybe she wants to continue her pregnancy. So she must know the risk of continuing the pregnancy and also the risk of the early delivery or the iatrogenic consequences of early delivery. And of course, the most important part of elective early delivery is the increased respiratory morbidity and the risk of admission to a special care PEPI unit following an elective cesarean section is 7 to 11% at 37 weeks of gestation. And of course, this risk is lower when we advance in pregnancy, 6% at 38 weeks, 1.5% at 39 weeks, and data in obstetric cholestasis pregnancy suggests that the risks are similar or maybe similar to normal pregnancy. So we have to be very honest with the patient to tell her that it's better to offer induction of labor at 37 weeks to avoid the maximum time of fetal risk of stillbirth. But also you have to put in your mind that there is some sort of increased respiratory morbidity due to the elective early delivery. As I said, the decision should be made after careful counseling. Women should be informed of the increased risk of perinatal and maternal morbidity from early intervention at 37 weeks, and also she should be informed of the inability to predict stillbirth if the pregnancy continues. Am I clear so far? Okay. What about the treatment? How to treat the conditions? Another challenging point is the treatment, as also there is no evidence that any specific treatment improves the fetal or neonatal outcomes. All such therapies should be discussed with the individual woman with this in mind. When you offer any treatment in a case of obstetric cholestasis, you should tell her that all these therapies, we don't have a strong evidence that they may improve the fetal or neonatal outcome. First, we can use the topical treatments, topical emollients, to make some slight temporary relief of pruritus. They are safe in pregnancy, but their efficacy is unknown. There are some other systemic treatments for pruritus. They include the drug known as cholestyramine, and this is a poorly tolerated bile acid chelating agent, which may improve pruritus in some women. But the problem with cholestyramine is that it exacerbates the vitamin K deficiency. And this has been associated with fetal intracranial hemorrhage. Until now, cholestyramine has not been subjected to randomized trials and is not in clinical use in cases of obstetric cholestasis. Systemic antihistaminics like chlorpheniramine may provide some welcome sedation at night, but do not have a significant impact on pruritus. So you can offer antihistaminics to, help the patient to sleep at the night, as these antihistaminics provide some sort of good sedation at night. We have also the oxycholic acid. This is a very common prescribed agent in the UK for relief of pruritus and obstetric cholestasis. So we can say that this is the first drug to be used, also the oxycholic acid. It protects the hepatocytes from the damaging toxicity of bile salts and also enhance the bile acid clearance across the placenta from the fetus. It improves the pruritus and liver function in women with obstetric cholestasis, but also you have to counsel the woman that there is a lack of robust data concerning protection against stillbirth and safety to the fetus or the neonate. It improves the liver function test, improve the pruritus, increase the clearance of bile acids from the fetus. Yes, that's very good, but we don't have a strong evidence that this can protect against the stillbirth, and also we are not sure about its safety to the fetus or the neonate, especially the long-term consequences. This is also the oxycholic acid. Another drug is the S-adenosyl methionine. This is a naturally occurring substance in the body, but also they made synthetic forms of it, which is found in some dietary supplements. And there is insufficient evidence to demonstrate that this drug is effective for either control of maternal symptoms or for improving fetal outcome, and it is not recommended. This drug is used in many health problems. Some of them are psychological health problems, also liver diseases. There are many trials of this drug in different liver diseases, but we don't have a strong evidence about its safety and its benefit in using or in controlling the maternal symptoms and improving the fetal outcome. And according to the Green Top guideline, it is not recommended. Dexamethasone or corticosteroids should not be used for treatment of obstetric cholestasis as a first-line therapy, nor should it be used outside of a randomized controlled trial without a thorough consultation with the woman. In some cases, they give the dexamethasone when the oxycholic acid failed in controlling the symptoms. But you have to counsel the woman and make sure that she understands that there is no strong evidence about the safety of long-term use of corticosteroids in pregnancy, especially that there are some claims that the repeated uses of corticosteroids in pregnancy may affect the neurological development of the newborn and the child later in life. So dexamethasone If will be given, it will be given if there is a failure of the orthodeoxycholic acid. It should not be given as a first-line therapy, and also it's not recommended to be used outside of a randomized controlled trial without a thorough consultation with the woman. But of course, we give the dexamethasone as a corticosteroid injections for the fetal lung maturity. When we offer elective delivery, of course, you are going to give the course of dexamethasone needed for the fetal lung maturity, but not for the treatment of obstetric cholestasis. Clear?
Yes, sir.
Okay. What about the role of vitamin K? As we said in the pathophysiology that there is a malabsorption of vitamin K and fat-soluble vitamins in general. So we have to offer water-soluble forms of vitamin K. It's called menadyl sodium phosphate in cases of prolonged prothrombin time. When we do a coagulation screen and we found that there is a prolonged prothrombin time, you have to discuss with the woman and offer her a water-soluble vitamin K, which is called menadyl sodium phosphate, in doses of 5 to 10 milligrams daily. And this is a Green Top guideline recommendation. If the vitamin K, if the prothrombin time is normal, should we give vitamin K or not? According to the Green Top guideline, if the prothrombin time is normal, discuss with the woman, you can give her vitamin K. There will be, of course, benefit from the vitamin K, but small theoretical risk. And let me say that this is a very historical and theoretical risk. Actually, in the clinical practice, there is, rarely to find that vitamin K can cause neonatal hemolytic anemia, hyperbilirubinemia, and kernicterus. Actually, this is vitamin K toxicity in preterm babies. If there is vitamin K toxicity, giving vitamin K in large doses can affect the RPCs of the fetus or the baby and lead to neonatal hemolytic anemia, hyperbilirubinemia, and kernicterus. Also, the high doses of vitamin K may lead to increase in the bilirubin level, but this is a theoretical risk because we need very large doses of vitamin K to do this toxicity. So vitamin K can be offered even in women with prothrombin time or normal prothrombin time, but you have also to give her an idea about the small theoretical risk of neonatal hemolytic anemia, hyperbilirubinemia, and kernicterus, although this is a very historical risk and it's rarely seen in clinical practice. And postnatal vitamin K must be offered to the babies in the usual way, Yes, vitamin K we are going to give in obstetric cholestasis, especially if the prothrombin time is prolonged. Yes, 5 to 10 milligrams per day. But if the prothrombin time is normal, you can give or not. This is according to the preference of the doctor, but you have to counsel the woman that she is not in great need for vitamin K if she has a good coagulation profile. But if she wants to take vitamin K, she should know about that small theoretical risk. You are welcome. So that's the treatment of obstetric cholestasis. And the last point to talk about is the follow-up and the prognosis of the condition. Women should be offered follow-up with a healthcare professional with the necessary skills and expertise to provide appropriate counseling and to ensure that liver function tests have returned to normal. Usually, complete recovery occurs within 48 hours or within 2 days of delivery. Some rare conditions may worsen postpartum and liver function tests return to normal slowly, taking 4 to 6 weeks to reach normal values. But this is not the case, or this is not the rule. Usually, or most of the cases will resolve completely within few days after delivery. And as I said before, put in your mind to defer the liver function test at least 10 days, as there is some sort of increased liver function test in the first 10 days of the puerperium. So be careful, as the results may be inaccurate. So defer the liver function test for at least 10 days. And by this, we come to the end of our topic, the obstetric cholestasis. If you have any questions or any comments, I'll be happy to listen to yours. Thank you so much. Please don't leave, as our course coordinator, Mafia, wants to talk to you about the course.
Dr. Mohammed.
Yes.
Hello. I just want to ask about, yes, can we diagnose obstetric cholestasis while liver enzymes are normal?
While liver enzymes are normal?
Yes. And the patient has pruritus, just
yes, see, if we have
in the soles.
Yes, if we have typical pruritus, for example, if you have typical pruritus like that you are saying, but the liver functions are normal, okay, and you are repeating them and they are still normal, and you don't have any other, causes of that pruritus, I think, of course, this is not clearly written in the guidelines, but I think from my humble experience that I will think about obstetric cholestasis. Even the liver function appears normal to us. And as I said, we usually don't use the pregnancy specific ranges, and that's a very important point, that usually the liver function tests are 20% lower in pregnancy than the non-pregnant state. So you have to make sure that with the laboratory that these are pregnancy specific ranges, not normal ranges outside the pregnancy, okay? So what appears normal in pregnancy may be high, okay?
Okay, thank you.
You're welcome. Thank you so much for your kind words. Thank you. Any questions or comments? Thank you. Okay, now I'm leaving the mic to Mafia, our course coordinator, and she will talk about the course and the mid-exam gift for the today.
Thank you so much, Dr. M.helmy, for the lovely session.
Thank you, Mafia.
Hello, everyone. Hope you all are doing well. I am Mafia from the backend team. Today, I will guide you how you can join our course. So let's discuss about the course. So first of all, let me tell you that this is our 3 months regular course. First of all, let me tell you that our course is starting from 16th of March 2021. Then our course mentor is Dr. M.helmy, you all are already familiar with. In the 3 months regular course, you have live sessions, then we have topic tests, mock exams, session recordings, and study group. In the live session, you can directly interact with your mentor. After the live session, you can test your preparation through the topic test. Once you have completed the course, you will be able to give the mock exam. If you have missed any session, then the recording will be also available on our website. Then we have a study group where all of your queries will be addressed. Then here we have a special gift for all of our audience. You can buy our course on 50% discount. Discount is available for 24 hours only. So first, how you can register to the course? First of all, you have to sign up on our website as shown in the picture. You have to click on the sign up. Once you have completed your account, what you have to do is you have to click on this course catalog. From that, you can pick your particular course. Let's say you have to pick this MRCOG 1 course, which is for July 21. Once you have clicked on it, you have to click then this course now. Once you will click on it, there will be a dashboard where you can add this coupon. Once you will add this coupon, your payment will be changed from $4.50 to $2.25. Please keep in mind that it's for 24 hours only. So please let me know if you guys have any question so I can answer. So
Yes, Dr. Christina, yes, it's this offer from Medex exam is only for 24 hours.
yeah, it's for 24 hours. If you want to join the course, you can drop in the message on our number. Here is our WhatsApp number. Even you can drop in a message on our Facebook page. You can even drop your message via email. Our email is info@medexamexpert.com. Thank you, Dr. Zoomer. Anyone else, please let me know if you have any question regarding our course. Yes, definitely, team will help you, Dr. Zoomer. If anyone's query is not addressed, you can directly drop the message on our Facebook page, or even you can drop a message on our WhatsApp number. You're welcome, Dr. Zoomer. Dr. Christina, I have already explained how you can join the course. Can you please share the link, backend team, please share the payment link in the chat box so students can join directly by clicking on the link. You can directly join our study groups too. Guide groups. You can just click on the link which team will provide you. Please, backend team, can you provide the guide group links?
Okay. Well, the backup team will share now the links of the guide group, okay?
Yeah. Any other query, please? You're welcome, Dr. Sam. Yes, backend team have shared the payment link. You can directly click on the link for the registration. Thank you. Dr. Paloma, registration link already shared. You just have to click on the given link. Thank you, everyone. I guess, Dr. Helmy, we have to cover all the points.
Yeah, thank you so much, Mafia. Thank you for your explanation.
You're welcome.
Hope you all enjoyed the session. And of course, we are available all the time in the guide group and also in our Telegram group. If you need any question, you can share. And of course, we are here to help you all. Thank you so much.
Thank you so much.